Good afternoon, and thank you for joining us for today's Nevada Immunization Learning Exchange, or NILE, webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue. Second, please locate the Q&A box at the bottom of your screen. If you have any questions, type them there and we will address those questions at the end of today's presentation. Additionally, if you have requested continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, or in tomorrow's follow-up post-webinar email. There is no need to complete that survey twice. So if you do that today, you have completed the requirements for CE attainment. All CE certificates will be emailed out within the next week. Some information about CME today. In accordance with the AC CME standards, all speakers are required to disclose any to the program audience, any real or apparent conflicts of interest to the today's content in today's presentation. Today's speaker, Dr. Espinosa, is a vaccine advisor to Sanofi Pasteur, a vaccine manufacturer that does not make an HPV vaccine. She has also received a grant from Gilead and has participated in other non-HPV vaccine sponsored trials. In addition, she is on the Speakers Bureau for the Kentucky Rural Association. Accreditation and designation statements can be found here. In the interest of time today, we ask that if you'd like to learn more about this piece, you may review it when the webinar and support documents are made available on Immunize Nevada's website. Also to note, the webinar for today is being recorded. The archived presentation and slides will be available on immunizenevada.org/NILE within 1 week. And before we officially begin, I'd like to provide a little disclaimer. Immunize Nevada NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization related topics through a non-branded, unbiased presentation. I'd like to now turn it over to today's featured presenter, Dr. Claudia Espinosa. Dr. Espinosa attended medical school in Columbia, completed a residency in pediatrics at the University of Kansas School of Medicine, where she served as chief resident, followed by a dual pediatric infectious disease fellowship and a Master's of Health and Science in Health Services Research. Dr. Espinosa served as an assistant professor of pediatrics at the University of Louisville School of Medicine in 2012, and as an associate professor after 2018. In 2019, Dr. Espinosa joined the Department of Pediatrics Division of Infectious Disease at the University of South Florida. Welcome, Dr. Espinosa.
Thank you, Brianna. And thank you also for the invitation. And this activity is a partnership, like Brianna said, between the American Academy of Pediatrics and Immunization, Immunize Nevada. So I'm really happy to be here today. And we are gonna talk about addressing parental vaccination concerns and some tips in how to maintain immunization rates in the midst of COVID. I hope everybody can hear me okay.
Yep, we can hear you. The audio is great.
Perfect. Next. Like Brianna said, I have the disclosures. I had been advisor for Sanofi Pasteur. I received a grant from Gilead, and I am also a Speakers Bureau for Kentucky Rural Association. Next. Today, we are gonna try to describe the vaccine hesitancy as a public health concern, also review some reasons for parental vaccine refusal in pediatric practices, and discuss communication strategies to manage successful vaccination conversations, identify parental specific concerns about vaccination, and explain the importance of maintaining routine immunizations during these unprecedented times of COVID. Next. And before we start, I really want to go through some definition, but The importance of this topic of the vaccine hesitance is really that, ironically, in the 20th century, probably there has not been another intervention that has been as successful in saving lives as vaccine. But in 2019, the World Health Organization has listed vaccine hesitancy as one of those 10 major threats to global health. And so we really need to understand this topic, and we can be more prepared to tackle in our practices and actually do something about it. Vaccine hesitancy has been defined as a delay in acceptance or refusal of vaccines despite the availability of those vaccines in the practice. And it is not a one-way concept. Is really complex and context specific. For example, many people or some parents may be unable or not willing to vaccinate their kids for MMR, but they may be completely fine to do it for Hep B. Other ones may not be completely easy to vaccinate at birth, but they may do it when they go to the pediatrician office 3 days later to have the Hep B for the baby. And so it's really complex to understand all the things that happen in the mind of these parents who are refusing vaccine. Vaccine acceptance, on the other hand, is a timely receipt of all childhood vaccinations as they are recommended by the ACIP when they are available. And confidence really is the trust that parents or providers have in the recommended immunizations, in the providers who administer those vaccines, and the process of licensure and vaccination schedule, which is not the same on all patients. Next. So with that being said, let's try to get to the first objective, why it is a public health concern. And next, through the whole history in the world and around the world, we have seen many examples that the impact of a drop of vaccination rates have in public health. For example, maybe you don't remember, but in the mid-70s, there was the wholesale pertussis vaccine, which we don't use it anymore, was associated with encephalopathy. Vaccinations rate decreased in many places, in many countries, including UK. And that was followed by an epidemic of about 100,000 cases of pertussis and 36 deaths in about only 4 years. Same happened in Sweden. In Japan, for example, where the vaccination rates decreased from 70% to 20 to 40%, there was a jump of 3,000% in pertussis cases in about 5 years. The same happened with the MMR when it was linked to autism in 1990s. There was a decline in vaccination in the US and the UK, and that was followed by many outbreaks of measles. And now we know from different studies that 5% decline in MMR coverage results in about 3-fold of increase in cases per year. Next. So here is epidemiologic kind of overview of measles outbreaks since 2000 to 2015. There is this curve is the cumulative epidemic curve of 18 different outbreaks. The first bar right here, if you can see my my pointer, is the day 1 when the index case are seen, and oh yeah, you cannot see it, I'm sorry. But anyway, and then the other cases show up along with the, as time passed by. And what we can see in this graph really is, if you look at the colors, the unvaccinated patients are the purple colors, but there are so many vaccinated cases also, or infection in vaccinated cases, those are the green ones. So the bottom line of this really picture is that these outbreaks are not only affecting those parents or patients who decide not to vaccinate, they are really affecting everybody. Next. And there is evidence that promoting healthy vaccination behavior benefits society. Immunization campaigns at the beginning of the 20th century in the United States had the following impacts, for example. Decrease in the number of kids that were killed by pertussis from 8,000 per year to only 20. The number of patients who were affected by poliomyelitis from 50,000 to 0. The number of measles deaths decreased from 3,000 to 0. The severe birth defects caused by rubella came down from 20,000 to 0. And the number of people with meningitis and bacteremia and the sequelae of those diseases for Haemophilus influenza also decreased from 20,000 per year to 100, to the point that many medical students nowadays, or other providers, they don't see these diseases. So the implications of outbreaks are really more than what we just can see in the news. For example, this is only one example of those outbreaks of measles that I was talking about before. And this happened in 2005. And it happens because an unvaccinated teenager went from a mission trip from Romania. She did not have vaccines. She went to this mission trip and spent several days there where measles is endemic. And when she came back, she was incubating measles, but she did not have any symptoms. The next day, she attended a church gathering with about 500 people in there, and in total, there were 33 people infected. 3 of those people were hospitalized, and one of them was in ventilator for about a week. In the graph, in the first graph in the left, we can see when those cases occur. So the dates when they occurred, we can see that many of the people got infected at the gathering, but then after that, because some people will get in contact with these people that were infected, so some household contacts, more people got infected through the days after the outbreak. And here on the right, we can see the number of people who at the end end up being affected. And again, we can see that the clear bars are the unvaccinated, and the dark color is the vaccinated. And 2 people had vaccines, but still got the infection. From this outbreak, we can just make some summary of what happened. And it was that most of these patients that were affected were at the same church. The church really didn't have any position regarding vaccines, so it was a subculture within the same church. Some vaccinated people got infected too, which is really unfortunate. And there was one unknown case in which he didn't have, and this phlebotomist at the hospital didn't have absolutely any contact with any of these people from the church, but it still got infected. And how much does it cost really in terms of money, right? And it is really a costly disease, just this outbreak, when they end up breaking out everything that was invested on, number of people that were, the personnel that were involved, the time spent in the investigation, the number of extra doses they have to give, right? Not only to the people that were unvaccinated, but the other people that were not catching up with vaccination. The materials and activities and actually the money, right? It was estimated that about $167,000 was what it was costing this single outbreak in 2005. So outbreaks are not cheap. Next. And here, when we listen to parents talking about hesitance of vaccine, we really need to make sure that they understand what is the price they want to pay for natural disease. So either we get measles infection, and then we get 1 hospitalization in 4 people who are infected, 1 pneumonia in 20, encephalitis 1 in 1,000, or 1 in 1,000 people may be death. Or we just suffer the side effects of the vaccine, right? fever, which is transient and it doesn't last and is 5 to 15 in 100, or a rash, which is transient too, 5 in 100, arthralgia, which is very transitory too and happens mostly in women, or thrombocytopenia, which as a matter of fact, it's also transient and it happens in 1 in 30 to 40,000. So those are the things that we need for them to understand next. Now let's pass to another topic. Let's talk now about why parents are deciding to refuse nowadays vaccinate their kids next. And first of all, we need to understand that really the majority of the parents will accept the vaccines. This is a graph from 2017, and they are looking at how many children are vaccinating or have all the vaccines by 24 months of age. And here we can see that 98.7% of people or children are really vaccinated. It's only 1.3% that are not willing to vaccinate and they refuse completely vaccination. The problem is in the left, in the right, we can see that the number of those parents are increasing per year. So in 2011, it was 0.9% of parents who had problems with vaccination. And then in 2015, it was 1.3. Next. And the vaccine hesitance is not only being seen in parents. So here in the first graph, we can see that 1/4 of children in the United States are nowadays following an alternative schedule. 2/3, the middle graph is 2/3 of parents in the United States have serious concern about vaccination or adverse events of vaccination. But providers are having that issue too, because 3/4 of the providers are willing to spread the vaccines out, telling or saying, dispersing the message that maybe they are not that safe, or maybe parents who are hesitant or refusing the vaccines are right. Next. All states in the United States allowed parents to exempt their children from mandatory kindergarten vaccines for medical reasons. That we can understand that, right? There are some contraindications, there are allergies, anaphylaxis, and we know that. But 29 states also in the United States allow religious exemptions, and about 12 have religion exemptions and also personal belief exemptions. And right now, in 2009, actually, the philosophical belief or the non-medical exemption rise between or from 12 states to 18 states. And those 18 states are allowed policies that are much more relaxed about letting kids go into kindergarten without getting all the vaccines. Next. Well, and those non-medical exemptions are actually making up what this heat map is looking at, right? Because they, as we can see, they are strategically located in some geographic areas. So we can see Texas, many places, up north here, we can see New Mexico, some in Oregon, Portland, Michigan, and they are really concentrated areas, which is a terrible problem, right? Because those are the areas when if somebody that travels from a country to a country that doesn't have or has endemic diseases, then those are the places where outbreaks can show up. Next. And this is what happened with the vaccination rate coverage among those children less than 35 months of age in 2017. So you remember the heat map of the concentration of the places where there were non-medical exemptions. And those actually are the same places where we can see clear states here in this map, right? The ones who have less vaccination rate, at least for MMR. Next. And some investigators have really looked at this relationship between non-medical exemption rates and the actual rate of vaccine coverage. And what they have found is an inverse association between non-medical exception rate and measles, mumps, and rubella vaccine coverage of kindergartens to be totally inverse. And that being statistically significant, meaning that the more exemptions that the state have, the less people that they are gonna vaccinate, the less people that are gonna be vaccinated. Here I wanna show Nevada. Nevada is, I know this map is not really clear, but the gray bars are people who do not, who do not have vaccination. And then the dark are the ones that are up to date. And here Nevada, we can see that you guys are doing pretty good. It's like MMR vaccination is about 92%. Thank you, Brianna. Yes, like 92, 95%. So you guys are doing great. We wanna make it better. Next. But I did wanted to show you that that you guys are really are doing really good in terms of MMR. So there are different parents, and you as providers probably have seen all of these classes, right? There are immunization advocates, those strongly agreed with vaccines. They probably have been in another country where they have seen some of these vaccines, and those are about 33%. There are some go along to get along. Those are agreeing with you that vaccines are maybe necessary and that may be safe, but they are really not advocating for them. And those are like 26% of people. There are some health advocates. Those agree that vaccines are necessary, but they are not sure about the safety of those vaccines. And that is about 25% of parents in the United States. The fence sitters, those who slightly agree with the vaccines, and they really, they slightly think that they are necessary or safe, 13%. And there are about 3% of parents right now that are warriors or refusers, and they do not want to have the vaccines because they do not think that they are safe or that they are necessary. Next. So vaccine hesitancy and refusal is really a complex topic because it has its roots in the human nature. And you guys know how hard it is to understand human nature. Unless you are a psychologist, I don't know how really to explain all the ins and outs of this concept. But people really relies on anecdotal experience. So they place a lot of weight on anything that is anecdotally. And that usually leads to assume a cause and relationship that really doesn't exist. People really like confirmatory bias. In other words, that's the tendency to seek out evidence supporting what they already believe. So if you as a provider tell them that they are wrong, they are gonna ignore that and they are gonna look for another provider that agrees with them because they want the confirmatory bias. Humans have an intuitive sense of numbers. And so it is really hard to talk with parents about numbers and probabilities because it is difficult for them to see the big picture. For example, they totally can tell you many times what happened with those 3 kids that got vaccinated at a school, and after that they got diagnosed with diabetes, right? But they have really hard time conceptualizing a prospective cohort of 4 million person per year follow-up. They don't understand how that works. And scientists really, we work or we think more in probabilities. What is the probability? But that doesn't work with parents because they have heuristic thinking. And so it's hard for them to simplify those numbers to make actually a complex decision. They also are really tolerable with a bad outcome if they didn't do any harm. For example, they are better to have one of their children to have the disease if they don't go and vaccinate, rather than going to vaccinate and something bad happened to the kid. That's omission bias. And they also have, depending on the background, they may have many other cognitive and emotional biases that really makes the decision really a hard one. For example, some people may be really keen on doing automatic judgments on intuitive basis. For example, they think that one vaccination has relationship with the autism, and they circle back to analyze the same situation instead of going to look at the evidence, right? They just circle back and go to the same thing. Some parents may have a moral foundation that favors purity, like over degradation. So the purity of vaccines are dirty because they have antigens, but for them the real illness is not the same. It's also pure. So those arguments may not really help some of those parents to change their mind. They also see many times they see parents in where there is really no parent, but they see it because it is easier for them. And they actually, those parents that they see may lead to false associations. They believe sometimes that something or someone must be behind things. And maybe you guys have heard about that during COVID time. Just to put an example there, that is called agenticity. But for most of them, really all of them want to do the right thing. And that is something that we want to do too, right? So there is the common ground in all these conversations is the fact that we all want the best for that kid, that we want to have him protect them, and that yes, they are worried about them because they love them and they are doing what they think that they are doing right, but we also want to do the right thing, and that's when we have to be strong and firm. Next. So let's look at some communication strategies that are going to help us to manage successful vaccination conversation next. And one of the things that probably we need to make sure that patients understand or the parents understand is the risk versus the benefits. What are the risks of vaccinating versus what are the benefits? What are we getting from? And another thing that we need to understand is that the vaccines being safe doesn't mean that they are harmless, right? All vaccines may have side effects. They have pain, many kids have pain, many kids have redness. With HPV, some of them faint, right? But that doesn't mean that the vaccine are unsafe. Those are adverse events that are temporarily related to it, but they are not permanent. Also, it is very important that we make sure that they understand that vaccines are considered safe because the dangers they prevent far outweigh what the dangers they represent. And one example that I like to take, to present to my parents in the clinic is when they come for this, with these concerns is that, let's say every year in the United States, right, 350 people are killed in a bathtub, right, or in a shower-related accident. But we don't stop taking a shower just for that, right? 200 people choke every year in the United States because they are eating food, and we don't stop eating food, right? Because really doing all those activities have more benefits than really the risk that they represent. And the other thing that is really helpful to make sure they understand is the scrutiny and scientific rigor that those vaccines have to undergo before license. It's really amazing. And people underappreciate that. Next. And maybe we can, take a picture of this and maybe post it in some place regarding of what a vaccine really have to go through in the pre-licensure path to be able to be licensure. And it is a lot. It is a lot of years of research. It is a lot of animals and people that had to be going into the trials to finally for the FDA to license the vaccine. And once it is licensed in the post-licensure time, then there is the phase 4 studies that broaden the indication for other specific populations. They do pharmacovigilance, and we all know that any adverse events of vaccines or that we think they are related to vaccines, we can add it to the VAERS database, which is the vaccine adverse events database, right? And we always can do that in order to make sure that all these vaccines are as safe as they were before the licensure time. Next. And some of the effects of the vaccine with adverse events really have changed or modified what the recommendations are. And so that is what is the importance for all of us to report in VAERS. So if there is a noise, if there is something that we need to switch, then the ACIP and the other organizations that are regulating these schedules can be aware of that. For example, in any vaccine, if there is anaphylaxis, then of course the effect on the recommendation is that, and you can see it in every single vaccine, when you are looking at the contraindications, will be that you don't give any subsequent dose, right? For example, thrombocytopenia, right? That it has been seen in 1 in 30 to 40,000 people that receive MMR. The change in recommendation came up saying that if the patient has history of ITP or immune thrombocytopenia, it is a precaution for MMR. They don't say it is a contraindication because really this is a transient event, but you have precautions before giving it. In 1999, the rotavirus vaccine was actually associated with intussusception. 1 in 10,000 children that were vaccinated will develop intussusception. So the product was withdrawn in 1999. Febrile seizures with MMR-V with varicella when we do the combination vaccine, 1 in 2,300. And what that came up after was that there was a preference for the combination vaccine was retracted in the recommendations. So the ACIP said, no, it's better to give MMR and varicella separated, because when we give it together, there may be some increase in the febrile seizure presentation. Okay, next. We can go next. So the key points regarding talking to parents is that parents from all groups always try to include their health care provider as a source of information to help decide about their child's health. You guys are very important for the parents. They trust on you, especially when you have developed a long relationship. And most parents still vaccinate their children despite their concerns, right? We saw that 98% of children in the United States are vaccinated at some point. Next. Next. Some general recommendations about the whole discussion about hesitance with the vaccines. Start early. So many parents decide what they are gonna do about vaccination with the little one, even when they are even pregnant. So start the discussion really early. Have a plan. When they come to the clinic and they had vaccines, just tell them from the beginning, from the person, the medical assistant in the front, which ones are gonna be the vaccines the child is gonna get today. Start strong and be firm. Don't hesitate about what you believe. You believe vaccines are important, and you believe that the schedule as it is the recommended schedule. Normalize vaccination. Make them think that everybody vaccinate, which is true. You are not doing absolutely any lies there, right? Most people vaccinate, so make it as a normalization, as a norm. Avoid fact tennis. That is when they tell you, I think they have the vaccines cause autism, and you say, no, that's wrong because we have evidence that no, and then the parents say another wrong fact, and you counteract. When those conversations start like that, they usually don't go well because there is no change in the mind of the parent in regards to vaccination. They may actually not be at all more reassured about the vaccines than before they started the conversation. Use a team approach and organize visit effectively. If the parent is tired and has been waiting for a long time and they have to go to work and they have to finish with that visit really quick, well, there is going to be less receptivity for whatever you have to say. And on top of everything, they will probably make an excuse for not having time to give the vaccine or take the vaccines right away. Be consistent. So always recommend what the recommendations are. Stick with the schedule. And that way they know that you are serious about that. Deliver the information appropriately. Some parents may not like different ways of communication just because of the way they are, because their background. So I'm gonna go through different scenarios and different ways of communicating, so you guys can choose the one that you really like, or maybe you can just make some combination of those. Put things into perspective. Tell them about the 300 people who die in the United States every year because of the bathtub accident, right? Tell them really how many people or patients you get to save if you do the vaccines, and how many people you really avoid being sick because they are having the vaccine. And to be true, for those of you that do a really good job vaccinating and talking to parents and everything and spending time, right? To be true, we need to focus on that 99% of the patients. We know there's gonna be 1% of parents that no matter what you say, they never are gonna vaccinate. And we have to live with that. Be aware of the pitfalls. Next. And these are some of them. Because when we talk, and especially when we use our language, right, trying to be scientific, the parents may hear something different. And I'm just gonna, choose a couple of these ones because they are really interesting. For example, when you say that that something is positive, you think in your mind, yes, the value is more than 0, right? But parents only hear that is good. And there are some positive values that are actually bad. Same happen with statistically significant, right? For you, that means that the findings are not likely to be due to chance alone, right? That is the definition of a statistically significant finding. But for parents, they're most likely are gonna believe that the differences are important, which may not be the case. Next. More general recommendations. Listen to parents. Probably this is one of the big ones. Listen to what they are really worried about, because that is gonna save you time. Don't assume that all of them are worried about autism. There may be other reasons, right? So listen what they have to say. Promote partnerships with parents in decision making. So personalize, tell them you get the flu vaccine every single year. I give it to my children every single year. They really like to hear what you're doing with your own children. Discuss benefits and possible adverse events. Don't lie to them, right? Be honest. You tell them there are some adverse events, possible adverse events that not all children will present, but then you may see this, but the benefits are much more tangible and more important actually than those adverse events. Stress the number of lives that are saved by vaccination. Discuss the state law for school entry and why they are like that. Don't tell them it's because the government really takes away our rights. It's more because the government has this due diligence, right, with all people in the state, all people in the country. And so because they want to save all the other ones, that's exactly why we all need to vaccinate, because we want to do the good for the majority. Provide attitudes and beliefs that are linked to, the providers' attitudes and beliefs are linked to vaccination. If you are a strong believer of vaccination, if you really believe that this is what we need to do to keep our children healthy, then you are gonna transmit that, and your conversations are gonna be less complicated. Check back and summarize if they are understanding what you are saying, and if there are more questions after you talk to them. Next. Here it is an interesting study. They were looking at how do we recommend vaccines. And if the providers start the conversation, about 74% are gonna vaccinate if the providers say, this is what we are gonna do today. This is how we are gonna vaccinate. These are the vaccines that we are gonna do today. But when it is participatory, then only 26% are gonna do it, because the rest, you know, they are not gonna do it. Next. And when the parent has some resistance, also the attitude of the provider will affect how at the end the parent is or is not gonna decide to vaccinate. So if the person, if the provider continues to pursue the initial plan, about 47% of those parents are gonna finally accept. But if they don't, if they switch, if they accept the alternative schedule, then about 30% of those are gonna not accept the recommendation. Next. So if your recommendation is presented as optional, only 20 to 30% are gonna vaccinate. If it is a high quality, same way, same day, this is what we are gonna do, then 70 to 90% are really gonna be vaccinated. Next. So here are some examples. The optional. Have you thought about what shots would you like to give today? That may intentionally imply that shot is not important, or that few people do it. And that's how we come up with the low rates of vaccination. Next. On the other hand, if you presume that they are gonna do it, we have these shots today, then that implies that shots are important and that most people get it. And that's how we get higher rates of vaccination. Next. So here there are some strategies, and I'm gonna tell you the good ones and the bad ones too. Next. This is authors study this: ask, acknowledge, and advise. So ask them why they don't wanna vaccinate, acknowledge what their problem or their concern is, and just advise to vaccinate. Simple. When they did this study, they figured out that after 6 months, there was no change in vaccination rates. Those parents in the control group and in the intervention group, and that was a randomized trial. And the parents were still unwilling to vaccinate, just with the acknowledging and advice. Next. This one is announced. So announce the vaccination will happen and assume people are ready to vaccinate. Inquire, use open-ended question to understand what the person's concern is, and mirror, reflect back what you have understood to make the person feel heard. Finally, consolidate each conversation by securing trust. This is the AIMS approach. And this has shown some effectiveness because some vaccine acceptance conversations may be going well with this one, especially because you actually ask the parent why their concern were, and you reflect back on them. Next. Acknowledge, steer, and known. So this one is ask the parent, right? Acknowledge what the concerns are and clarify what the problem is. Steer the conversation, asking them or telling them that their misunderstanding are not correct. Know your facts and be confident and prepared. Next. The case is one of the ones that the Academy of Pediatrics really recommend. Let's do this example, for example, with vaccine-caused autism. And the case really stands for corroborate, is acknowledge the parent's concern and find some point on which you can agree. About me, tell them how you had prepared yourself to answer those questions. Science, describe what the science says and then explain in advice, give your advice to the patient. Let's go to the next one because that we have, so I'm sorry, can we go back to the other one? Yes. So ask the parent, right? They tell you if the vaccines cause autism. You tell them that you have been researching on the same thing because you have seen the same information in the web and in other platforms, right? And that you have gone to this conference, you have researched about this, you are up into the literature with autism, then describe the science. Tell them, from all my research, I have found out that there are no studies that can correlate vaccines with autism. As a matter of fact, in this last conference, right, we discussed about how autism can happen, and it is more a genetic disease than really something that is acquired. And then finally explain or advise, or tell your advice, right? Tell the parent that you agree and you understand that they are concerned about the child and that they want the best for them, but your advice is gonna be to vaccinate. Next. Easy is another one. Elicit parent main concern, acknowledge the parent concern without judgment, share commitment to vaccination, explain the science. Next. And motivational interview really has been used more and more in many healthcare issues, and including vaccine hesitancy. And this is really related to the patient-centered method for enhancing intrinsic motivation to change the health behavior. So it is trying to get from the parent what are the motivations that are gonna make him change the behavior, either vaccinate or not vaccinate, right? And this meta-analysis on the left, it's showing all these studies that have shown, have used in motivational interview for hesitancy in vaccines. And we can see that, you remember, if you are in the middle in one, then there is no difference between the intervention, meaning the motivational interview, and the no intervention. And if they are on the right, they favor the intervention. And if they are on the left, they don't. And most of these studies kind of show some improvement when you use this technique. Next. Next. Some tools that are used in motivational interview is asking open questions, being reflective, eliciting pros and cons, inquiring about the importance and the confidence in making a change, and summarizing the conversation. Next. And so now we are gonna see how we can apply this, right? I think that one of the important thing of this strategy of communication, which is called RULE, resist, understand, listening, and empower. I really like this one because the first part is really resist the writing reflex. When we are talking to parents and they say vaccines cause autism, our first thought is you are wrong. So this technique asks us to resist that writing in reflex. Don't tell them that they are wrong and we are right. Because that way we, in one sense, people are gonna be paradoxically maybe and easy to keep talking to you. And then second, they are gonna feel that we haven't trying to understand what is really going on in their minds. And so the second part is understand the patient motivation. And for that you need time to sit down and listen with them to see what the barriers are for them. Listen with empathy too. Don't try to be too biased or too strong, and just try to understand what they are coming from. And finally, empower your patient. Tell them this is what the research is, and you are the only one that can make the decision of whether or not to vaccinate. But if she was my child, then I will have done it. Next. So here we can see an example, right? Today we have two vaccines, the measles vaccine and mumps and rubella and the DTaP. And the mother replied to you, I don't want the measles one. And so how can we handle this? Next. First of all, resist that writing in reflex. Ask the parent to share the concern. So you seem to have some questions about the MMR vaccine. I want to make sure I answer all your questions. Let's talk about. You mind telling me what is going on? Next. The mom says that they are not safe, and you try to understand where she's coming from. You listen with empathy what she said, and then you ask permission to share the information. The provider listened and then ask. Let me summarize what I heard. So I can see that you are concerned that the MMR vaccine can cause autism. I have also heard some stories. It's okay if we go over what I know about the vaccine next. And so you can tell them about what you know, like we talked before. Avoid arguing and focus on this disease prevention. Next. And at the end, empower your patient and tell them that having said all that we discussed, and that the mother is the only one that can make the decision, are you gonna really not vaccinate your child? Do you think that, what do you think about vaccination now that you have heard all the conversation? Next. So some specific concerns, because we know that you all guys have heard these concerns in the clinic, and I wanted to make sure that we have some answers for these questions. Next. Many parents don't want to vaccinate because they don't think vaccines are necessary, right? They are not seeing these vaccines and they are not seeing these diseases anymore, right? Varicella, how many patients have you seen with varicella? When I started practicing, it was a every single day thing, right? But now it's really spread out because vaccines are good. And so many parents believe that the vaccines were already disappearing before we started vaccinating, and that's really not true. Vaccines save lives. They protect future generation. Some vaccines maybe act against some diseases that are not even, we will never get rid of. For example, tetanus. It's in the soil. We will never get rid of it. So that's what we need to keep vaccinating. International travel, we heard an example about that. Next. Some parents argue that it is better to be infected naturally than the vaccine-induced immunity. And although that may be true for some, right? For example, varicella, you get vaccination and you don't have to have a booster of infection to have long-lasting protection. But other ones are not. For example, Haemophilus influenza, that's one of the ones. And so what we need to make them understand is what is the price that they want to pay for immunity. Do they want to get the risk of having cancer if they don't vaccinate against HPV? Or they rather have the vaccine and be protected against all those 9 serotypes that are now available? Next. Many of them are terrified about the immune overload. And although, yes, in the past we only had like 8 shots by the age of 2 and only vaccinated against 5 diseases. And now we vaccinate against 16 diseases and have like 50 different doses by the age of 18. That is true, but the other thing that is true is that every day our immune system encounters many antigens. going to the park in a picnic, right? We are gonna be exposed to so many antigens, much more than vaccines maybe. And our immune systems are robust and they really respond well to all of them. Next. Next. And this is an example of them. We can tell them also this. In the past, the vaccines had many more antigens that they have now. For example, let's just look at the pertussis in the middle. In 1960, the vaccines have 3,000 antigens. In 1980, there were 3,000 antigens. Nowadays, the vaccine that we use only have 5 antigens. Next. Live attenuated vaccines may temporarily suppress or delay hypersensitivity reactions, but that doesn't mean that they are gonna really overload your immune system and are not gonna let you respond to other infections. Next. Next. Many people worry about the adjuvants. Those are there to enhance the response to the antigens. Aluminum is one of those that the people really worry about, but the reality is that children who by 6 months of age are gonna have only 5 milligrams of aluminum in all the vaccines that they get by the age of 6 months. But the ones that receive breast milk, they are gonna have 7 milligrams. And the ones that receive formula, they are gonna have between 38 and 170 milligrams of aluminum in their bodies. And anyway, they excrete it. So it shouldn't be a worry for many parents. Next. Additives is the other problem. Those stabilize the antigen and prevent the attachment to the vial. Many molecules can act as additives, and they are important for the process of getting the vaccine. Some of important ones are like the egg protein in the yellow fever vaccine and the gelatin and neomycin in the MMR. Those may cause allergic reaction, but they are really in a small amount. And none of the ingredients of the vaccines really had been proven harmful in the quantities that are used. Next. Next. Alternative schedule is another really bad problem because many people worry about too many vaccines too soon. But we have to stick with the schedule. If we don't, we are violating a social contract. We need to make sure that the herd immunity is enough so outbreaks are not gonna be out. And so that's what we need to do. Besides, alternative schedules have not been studied. They are not proven to be effective. Next. Allergies is another concern. Again, we are exposed to many antigens, microbes, and other things in many other encounters that we do. Do you know that every time we brush our teeth, there is gonna be a pass of bacteria from our oral flora to our blood, and we don't get sick. So it's important that they know that really allergies and autoimmune diseases are not related with vaccines, and many studies have shown that. Next. Next. I'm gonna skip these ones, but you guys are gonna have it in your package so you can continue and you can read over these concepts. Next. Some people worry about the fetal tissue. The only thing that is important here is that the first single aborted fetus was in 1960, and it was all the other vaccines are coming from that single cell line. So we haven't really used any other fetus to get this or create these vaccines. They are all coming from the same cell line. Next. We talk about autism. Next. Mercury, that's a good one, right? You can tell your patients that the thimerosal, which is actually the one that was used in the past in some vaccines contains ethyl mercury, which is not methyl mercury, which is the one that causes damage in the CNS. So there is no reason to be so afraid of that. Despite that, the ACIP recommended the removal of thimerosal in many vaccines, and only right now there is only few flu vaccines that have it. Next. Okay, I'm gonna go all the way to, Brianna, can you go all the way to tips in declination? Next one. What happened when after you spend all this time, they still do not want to vaccinate? Let them know that you are gonna keep offering the vaccines, offer reading material, and don't overstress. You did your part. Next. This part is about what the AAP really is recommending about vaccine hesitancy. And what are the provided options, right? Either scheduling longer well-care visits so you can talk about all these concerns, or simply not having the discussion and just skipping that they are not gonna have the vaccines and just don't worry about it, or dismiss those families from their practice. Next. It's very important that the AAP really do not recommend the dismissal. The dismissal of the practice is a really important decision. Next. Because anyway, parents really look for the health provider to get information about vaccines. And here is a study where they look at that, and they still will go to the health provider. Next. So it's important that we try to correct misconception about vaccines, and that we try to keep an open conversation with parents. Next. But we also know that providers are gonna be really worried, and many of them, right? We are worried about these kids that are not vaccinated in the waiting room with fever and maybe infecting other people, right? And so, although it is recommended the last resort, it's also an option. There are many ethical considerations. We have the obligation to continue to care for these families until they really find another place to go. Next. And so there are constraints that are legal and ethical. It needs to be conducted in a manner that is consistent and applicable to the state laws. Again, you need to give them 30 days at least, reasonable time to have another provider, to look for another provider. And many providers may not be able ever to do it because they are gonna be working in these rural places where they are the only providers. So it's hard to do it. Next. Next. And I think that I went over time, but I can spend 2 minutes here trying to see what are we gonna do with this, trying to maintain the immunization practices in this era. Next. This is what it has happening with MMR vaccination, and in the dotted line, and the straight line is the non-influenza doses, so all of them after COVID. In January was the first case, and is the first bar in the left, and then the second one is in March 13 when it was declared a national emergency. And then we all know that after March 16, probably all the practices kind of start shutting down for a while and all the restrictions. And this is what happened. All the vaccinations are really coming down. Next. So providers need to work with families to keep these children vaccinated. They are recommending to call back all those patients. It's gonna be a time-consuming effort, but it needs to be done. All those children who are in your practice that miss those appointments, and those that maybe did not complete or did telehealth but didn't get the chance to come to the office to get the vaccines. Next. Very important to keep all the neonates being seen between 3 days or within 3 days of being discharged from the hospital. Ensure that in your practice you have infection prevention policies that are going to be really reassuring for the parents, because many parents do not want to take their kids out of the houses, and specifically they don't want to use the healthcare services, right? So we need to make sure that they understand what we have done in our practice to make it safe, and carry on all those recommendations. Next. These are some of the education tools that the CDC recommends for these patients, that we have to talk to them every time that we see them, about how it is spread, how to protect, how it's important to use masks, how to clean and disinfect, and how to practice social distancing. Next. So one of the things that the Academy or the CDC is actually recommending is scheduling sick visits, for example, in the morning, and well child visits in the, sick visits in the afternoon, and well child health visits in the morning, because that way, you know, the rooms are gonna be cleaned overnight. There is not gonna be concerns about virus being spread for one room to the other one, and then they are gonna come all in the morning when they are completely healthy, and in the afternoon if they have any problems. Reducing crowding in the waiting rooms, and that's what they are asking. Even many parents practices are doing this, patients to remain outside until they are called into the room. Setting triage booths outside, and collaborating with other providers in the community to identify locations where they can see the patients. And the telemedicine, it's really a good strategy, but it's not gonna work for all the visits, right? When they had vaccines due, they need to come to the office. Next. There are many resources, excellent resources about hesitancy of the vaccines and keeping up with the vaccination in the American Academy of Pediatric websites. I describe or play some of them next. And there are other ones in the CDC. All of them are gonna be for you in your package, so you can actually look into those links and try to obtain more information. This is a hard topic, and it's hard to train pediatricians or providers in such a short amount of time, or how we are gonna counteract these problems. I'll be more than happy, Brianna, to stay and answer any questions.
Fantastic. I know that there was a few that have come through. Sarah, yes, this PowerPoint will be available. We will post it on immunizednevada.org/webinars within a couple of days, so that you guys can access these resources and then review further the great and really comprehensive information that Dr. Espinosa supplied us with today. It was a lot to fit in. It's a really complex issue, so I appreciate you guys that were able to stay on beyond that 60-minute mark. So in addressing questions, we'd address a question come in from Aubrey Hill. She said, I don't believe there's a connection between vaccines and autism, but in order to debunk that, can we explain the root cause of autism? Do we know? And then has sharing that information with parents been effective?
Yes, that's a great question. And, you know, we talk a little bit more about autism because it's like the, you know, the poster child for hesitancy of vaccines. And really, you know, I can tell you that hesitancy is gonna go completely away whenever we figure out really why autism happens. But in the meantime, we don't know why it is happening. And the reality is, right, you see the rates of numbers of autism diagnosis, and they have increased in the past 10 years. And it's not only because we are more aware of that, well, part of it is that, right, we have now a spectrum disease of these conditions, and we are more aware of it, so we are diagnosing more. more, but it doesn't seem that that's the only answer. So I have to tell you that there is not a good answer for that. I can tell you that dozens of studies have shown that there is no association, but in order to tell them, right, to completely dissipate all those doubts in these parents, really we need to find the cure for autism, or the reason for it. And the only thing that we can tell them is, you know, to keep in the up to date with information from the autism societies and what is going on with research in that area. I can tell you that so far most people believe that there are some genetic factors that are causing autism more than anything else. But the conversation should start with acknowledging, right? We all have seen that, we all have heard that publicity that have created, and telling them how, you know, the scientist who published the first study, the study was retracted, right? It was definitely find out that that person had done unethical research, and they did fraud with that study, and how there are all these other studies looking at it and not finding that association. So that may help a little bit with that difficult conversation.
Great. And then the next question that came in, how would you respond to those who are already hesitant about vaccines and the licensing process, who are concerned about the COVID vaccine being fast-tracked?
Let me tell you something. One of the things that we are trying to make a lot of emphasis now is to try to vaccinate against flu, because now that we are in this era, right? The CDC recommending, the AAP recommending, and we know that we need to do that. We don't want both diseases in these kids, right? We don't even know what is going to happen if they get both. And so it's very important to do that. And I can see the enormous amount of people who have refusals for flu and concerns and, you know, hesitancy and all that. And so when I think when we think on us scientists believing that hopefully COVID will finish when we find an effective vaccine, in my mind, I always have that, you know, the little pessimistic of me telling me probably I'm going to have a really hard time making, you know, having people vaccinate their children for this. But I think that first of all, we need to, you know, one thing that works on our favor is that we are all looking at this pandemic. Most of us have one person in our family or know somebody that either had been affected, maybe not dying, but being affected by it. And we can rely on those experiences to parents who have not seen it for some reason, right? And the second thing is to tell them that these vaccines are in a fast track right now. That's how the FDA had put it, right? A lot of money had been put on to make the vaccines trials to happen, but the FDA is not going to approve them unless they pass through all the stages that are necessary for licensure. Even if we are doing it in a rush, it's not going to happen until they do that. So that's something that we may be able to reassure parents. I know, for example, there are other countries, right? Russia has a vaccine that is already given to their country. That vaccine is not going to come here. It's not going to come here because it hasn't passed for all the stages that we require. The American, the FDA is really stringent especially with vaccines. So maybe that way we can steer the conversation. Whenever we have trials in children, which I assume is going to be much later than when the adults get them, we are gonna have all the pieces in place for making it safe for children.
Perfect. I don't want to go too much further over. We're almost 15 minutes over at this point, but any of the questions in the chat and in the Q&A box that we did not get an opportunity to address today, we absolutely will in post-webinar communications. We'll forward those on to Dr. Espinosa. I also just wanted to mention that the Executive Director, Leanne McAllister of the Nevada chapter of AAP, wanted to let AAP members know that they can sign up for a peer mentor to talk one-on-one with them regarding the implementation of some of the programs in your clinical setting to increase vaccination rates as well, just piggybacking on some of those points and advice that Dr. Espinosa has provided. So with that, I'm going to go ahead and wrap up today's webinar. Again, today's presentation and the slide set will be made available on immunizednevada.org/webinars. We thank you so much for being able to join us today and appreciate your participation and hope that you will join us for our next NILE webinar. Thank you, Dr. Espinosa.
Thank you, Brianna. Thank you, everybody.
Bye-bye.
Bye.